much. Okay, I'm going to give you a very, very quick whip through breech. I started this lecture probably giving it about over 10 years ago now, and originally I used to have 45 minutes, and there's more and more gone into the timetable, and my lecture got condensed, and then I got ECV added as well, so it really is a very quick whip through. The whole presentation will be on the website for you to have, and some of the slides I will go over very superficially, so it's just about a theme, but the stuff is there for you to read later. So what do I hope to achieve in the next 30 minutes or a little bit over? I want to talk about, I know it's old hat, but I think it's fascinating. I want to talk about the term breech study because it's why we are where we are now, and it's very important for us to understand that really as a lesson more than anything in why we need to be careful about well-meaning studies and just review the outcomes and what that did tell us. I want to consider one of the big studies that happened since then, which is called the promoter study, which all of the obstetricians in the room, I assume, will be aware of, but certainly for some of the midwives it may be a new thing. And I want to talk about the guidance that followed on from that. And then I'm going to give you a little bit on ECV, and then we're going to talk about a few things what I call pearls of wisdom for the management of breech delivery. And I'm also going to talk, as Kim already mentioned, about counselling skills, because I think if you counsel properly, the whole Montgomery thing is not really a problem. So what was the term breech study? The term breech study was an incredibly well-funded, well-run and really well-meant study in terms of what it did. It was massive. It had 121 centres throughout the world, and there were over, in 16 countries, I should say, which was one of the big issues. And of course, the UK took part quite significantly, but we weren't the biggest contributor. And into that study, there were over 2,000 women were recruited, and they were fully randomised according to the study protocol. In the caesarean section group, which were approximately half of them, 90% of those women had caesarean sections. And that's the first thing I'd point out to you. 10% of the planned caesarean group ended up having a vaginal breech delivery. That's why we need to talk about vaginal breech. And then we had another 60% of women who actually achieved a vaginal birth. And so it follows on that nearly 40% of them ended up having an emergency caesarean section in their planned labour. So there was an interim analysis done in the study. They'd aimed to actually recruit almost twice as many women, and what the interim analysis showed was that the study should be stopped, or concluded that the study should be stopped, because when you look at perinatal morbidity outcomes, effectively if you were a vaginal breech, you appeared to have a threefold increase in composite bad outcomes. In that the risks went from 1.6% for the elective section group to 5% for the emergency section group. And what it counted, and this is what I like to look at, is that it means in the vaginal group there's a 1 in 23 chance of a significant problem and a 1 in 74 chance of in the caesarean section group. Another take-home message: if you are a caesarean section breech, you are still not home and dry. There's an increased perinatal mortality compared to being a cephalic baby. And they also looked at some secondary outcomes maternal, and were pleased to report that in this study, in this short-term study, there didn't seem to be any great difference in maternal morbidity. So that was where we are, and that was what happened. And what happened from that is an amazing thing in terms of the power of research. So immediately after publishing this, of the units who had been participating, 92% of them changed to offering caesarean section immediately. The only ones who didn't, notably, were the French and the Scandinavians, and that's why we've got Promoter, so thankfully they didn't. But virtually everybody else in the whole world moved to saying, as all the guidelines said, you can see the three guidelines, the American College, our college, and the Canadian College, 2001, all their conclusion of their guidelines was all recommend caesarean section for breech delivery. Now, I've put you in a Montgomery world. That actually is a problem in itself, because we weren't really counselling women. And certainly, if you actually look back at all of those guidelines, none of them ever talked about the option of discussing the option with women. So what was the downside of that? The downside of that is if we actually look at what happened following 2001, we ended up with an increase in the number of free births for breeches, and that was happening in the UK to a degree. Certainly around 2005, there were a significant number of independent midwives who were doing breeches because local hospitals said they could no longer offer a vaginal breech delivery, which I don't think any of us would feel was serving fetuses very well. And we ended up with a lot of fetuses being home births, which is just totally counter to what we were trying to achieve. So what's happened since then? Since then, there have been a lot of reviews of the term breech study, and it has come under a lot of scrutiny and a lot of Criticism, I think, is a strong word, but they are what the criticisms were. The biggest criticism is this was a randomised study, and for something that is a very complex procedure, we shouldn't have done a randomised study ever. We should have done a cohort study where women were actually allowed to choose what they wanted, because that would get away from the biases of the woman. As you imagine, in a randomised study, if you were a woman who really wanted a section and you have a vaginal breech in your randomisation, you may well be somebody who during labour opts out and you're going to end up with a caesarean section. And likewise the other way round, if you really wanted an elective section and you have a vaginal breech, you're not really going to be committed to doing the things that might improve your outcome. The other things were that there were very poor selection criteria. There were a number of protocol breaches. They seem to be more commonly in the vaginal breech group, in that there were, for example, an anencephalic baby who was randomised to the vaginal breech group. That baby was never going to survive and was always going to be a perinatal mortality, but it was included in the analysis. And the other thing was, and very, very importantly, there were no requirements that anybody had to be particularly skilled to do a breech delivery. Many of the units didn't even have an obstetrician at delivery. Nearly 20% of units had no obstetrician at delivery, and there was no requirement, there was no protocol, you didn't have to deliver in a particular way, no recommendations. It was a free-for-all in how you delivered your breeches. And certainly what we know is that, if anything, it sanctioned certainly a very conventional breech delivery, legs up in lithotomy as soon as you see the bottom, fingers in the groins, traction, do all the manoeuvres. Oh dear, we've got nuchal arms, and what a surprise, the head's extended. They were the sort of things that were being sanctioned effectively in some of the other countries in the world. Secondary outcomes were looked at as well, and there were some very interesting things in that. One of the most interesting things was the massive rate of augmentation. So there were huge uses of syntocinon in the term breech study, much more than we would have expected. There were things that small babies, as we would expect, and long second stages, things that a good protocol wouldn't have allowed to happen, were problems, and the babies did badly. The other thing that some of you, I don't know if I've got people who trained abroad, will know that one of the big things with perinatal mortality was worse in countries with low perinatal mortality. So in other words, in this country, we were the ones who did worse, whereas in India, if you had a vaginal breech baby, your baby was much less likely to have a bad outcome. So we also did studies, and this just mentions 2 years, but 2 years and 5 years have shown that in the babies that survive, there's no difference in outcomes. So this is a very short-term problem. So that's where we were, and we said what happened. So just to mention to you Promodus, as I said, the French didn't stop. They continued doing it. They said, we quite like doing vaginal breech deliveries. We do a quite interventionist vaginal breech delivery, but we're going to do it with a very good protocol. And what they did was they did effectively an observational study, which was done in France and Belgium in 2006. And again, they randomised a very large number of women. So there were 5,500 women in the caesarean section group, which goes along with the fact that women go and do their research and were reading about the term breech study and were choosing elective section. But they had 2,500 women who elected to have a vaginal birth. And what their study showed is that there was no difference in the perinatal outcome. But it has to be said, they had very strict selection criteria. You certainly weren't allowed to have a vaginal breech birth if your baby was below 2.8 kilos or above 3.8 kilos. You signed up to being on a labour ward with an obstetrician who was experienced in vaginal breech birth, and also quite an interventionist, which I'll mention later on in the talk, type of vaginal breech delivery. So this study resulted in a slight change in direction, and I'll call it a slight change in direction. And the, oops, did I skip over two? Yeah, so skipped over two there. So the RTOG guidance was the first one to come out in 2006, and we softened very slightly. And so what we said is that planned caesarean section reduces perinatal mortality, that caesarean section increases some maternal complications, but it doesn't carry any long-term risks to the woman. And long-term risks for the future seem to be uncertain. And we were very kind of, you need to think about what you're going to tell women, but not with that strong recommendation of a caesarean section. If you go back and read it, it doesn't anywhere say recommend caesarean section. Nor, unfortunately, did it ever say a lot about counselling. And that's one of the things that I think most people would criticise it as a guideline for. And then following on from that, the Americans followed us shortly afterwards, and not surprisingly, they really stuck with tell the women a few things that basically the baby might not do so badly, but still continue to recommend caesarean section, was what the Americans said. And the Canadian College Guideline, which I would recommend you all go and look at because it's an extremely good guideline. They have different rules about the way the guidelines are written and different ways of interpreting evidence and levels of evidence that can be put into there. So to me, it's a much more practical guideline than the RCOG guidelines are allowed to be, because our scope doesn't allow us to do that. So I'd recommend that to you. It hasn't been updated. Neither of these guidelines have. Both of them have effectively said re-reviewed 2016, and both are guidelines that still stand. So where are we now? The thing I would say to you is that what we should be doing is we should always be thinking about whether, and certainly Montgomery means this is important, that we should be considering and discussing the option of vaginal breech birth with women where it is clinically appropriate, that is something there. And that should be done in an unbiased way with individualised risks. We should be honest about the experience that's available, and some of you will work in units where everybody will say, I really don't feel I can do a vaginal breech, and that is allowed. You are allowed to be honest about your experience. And you may be obstetricians and midwives who are sitting around me and saying, fine, that's what I'm going to be. I'm going to be that type of obstetrician. And that is fine. You can be that sort of obstetrician if you want to be. We offer and recommend ECV, and I'll come on to that a little bit more in a minute, but it's absolutely imperative, whoever you are and whatever you believe about breeches, we must be offering ECV to women. And we need to, if we're going to actually go for vaginal breeches, we need to do like Promoda did, and we need to make sure that we select women very carefully. So we scan them, we take their history, we look at the neck position, and we talk to them about the things that we're seeing, the size of the baby, in relation to whatever they feel their wishes are. And the most important thing, I would say, and it's always been there, we've been saying in the UK, woman-centred discussions at all stages of care for years and years now. It's still in America something that's a bit foreign to them, but in the UK it's something that we have there. Now, Kim mentioned this before, and I put this up, I've used this slide actually in my last presentation, and I think this to me is what Montgomery is about. And it's about remembering that it's not our view of a risk that matters most, it's the woman's view of a risk, and that's really what Montgomery is saying. So how we see a risk depends on so many things. I've always said, if I said hands up, and you don't need to do hands up, who would do a bungee jump here? I'd get about half of you put your hands up, and I said, who would never dream of doing it? Half of you put your hands up, and who are wavering in the middle? Some of you would be in that group, because we perceive risks in different ways. So it's about our past experience, about our personalities, about our values placed on outcome, and that's very important for the women, because we, unfortunately, our holy grail is healthy babies and nobody going to NICU and not having to do a risk management report, but they don't necessarily think of the outcomes in that way, and of course the assessment of the evidence. So there are two ways of doing things, and the one that Montgomery doesn't want us to do is be paternalistic. We must not do this thing where we go, well, what I do is, because it doesn't matter what you do, what matters is what she would do. And you tell her what she should do based, as I say, on what you would do. So it's a completely wrong thing to do. And certainly in terms of when we get into Montgomery, it's about the fact that most of us don't like the idea of very high caesarean sections, but that isn't really the primary thing. She has different things that are important to her. So what should we do? We should do shared decision-making, and shared decision-making means that our role is to explain to her the evidence, because evidence is complicated, isn't it? Trying to get the average woman to understand the complexities of the term breech study and Promoda is difficult. That's our job. Our job is to explain that evidence and give them a summary in language that they understand. We need to make sure that they understand that, and that's where leaflets come in and all of those other things that we should do. And then we support a decision, whatever that may be, and try to make that as safe as possible. So, new RCOG guideline, obviously, as like I said, I couldn't go without putting it up there. I'm biased, and so I think it's a good guideline, but the most important thing about the guideline are the massive pleas for counselling that there are through it. So I'm not going to go through all this diagram, but this diagram that I've been using here still stands, and the most important thing in this, in terms of when you have this woman who has an antenatally diagnosed breech, is the first thing is we think about ECV. Forget anything else. Doesn't matter what else is going on, whether she's going to want a vaginal or a caesarean section, our first thought should be ECV always. And there are obviously a small number of women who've had 3 sections, and you don't need to do ECV in them, but apart from for them, we should be doing ECV in all women and offering them. So ECV guideline is there. This one really isn't radically changed from the previous guideline, though there are a few small things which I will just highlight to you. So the important thing about ECV is that it's not a perfect technique. It only works in 50% of cases, but 50%, as I always say to women who are thinking, well, that's not very good, it's 50% better than nothing, and it may allow them to have a vaginal delivery. And that, of course, is the most important benefit, is if it's successful, it reduces caesarean section rates. People worry and say, oh, well, will my baby turn back? The evidence says no, they very rarely turn back. The other thing to tell you is that, unfortunately, where a baby is, you fail with an ECV, the chances of it turning to cephalic are also very, very low. So although we all live in hope, most of them don't turn by the time they come in for their caesarean section. So we need to offer it because it will reduce caesarean section rates and give women that as a benefit to it. We need to make them aware that there is a very small risk of, I shouldn't say that, you see, they need biased counselling immediately. I tell them that there is a 1 in 200 chance, so 199 out of 200, and make sure they understand that there's that chance that they will need to have an emergency delivery on labour ward. But in fact, because it's such a low risk, we no longer recommend that they're prepped for caesarean section. We just need to do it. They don't really need to be starved. They definitely don't need to have any analgesia. We just need to make sure they've done some sort of either verbal or written consent, depending on the policy in your department. The vast majority of women are suitable, and previous caesarean section is not a contraindication. There have been a number of studies that have looked at that, and it's definitely as safe in previous caesarean section as it is, so it's not a contraindication. And the only real contraindication would be a significant fetal abnormality or a very growth-restricted baby, I would say, and recent antepartum hemorrhage, I think, because of the fact that you can precipitate abruption. So if you've got somebody you're worried might have had a recent marginal abruption, they would be the only real contraindications to doing an ECV. The ECV guideline, just for the midwives in the room, I added this bit in because it didn't used to be in my slide, but I knew there were midwives, so I just added it in just now. Moxibustion is actually recommended in an RCOG guideline, believe it or not. It's actually there because there is evidence that with skilled and properly trained practitioners, it does reduce the incidence of breech. So, assuming they can afford moxibustion, because it's not the cheapest procedure in the world and it isn't available on the NHS, we should be recommending they think about it. But the one thing that if you look at the evidence about optimal fetal positioning and telling women to spend hours scrubbing their floors or in all fours watching television, there's no real evidence that that makes any difference. So how can we improve our success? Who in the room here does ECV? If all of you do ECV, so a very large percentage. So, you know, I mean, everybody develops, in my opinion, their own technique. The thing I would always say is the technique has to include getting the presenting part out of the pelvis. If you cannot get the presenting part out of the pelvis, you're not going to succeed. We know that people who do ECV regularly are more likely to succeed than the people who do it ad hoc, and therefore you should try to cohort your ECVs into little groups so that people who are good at them do them. 36 weeks in primips and 37 weeks in multips, and we all know who do the ones who do ECVs. You love the para 2 who comes in because of the fact that you know it's got a good chance of turning. Tocolysis, at King's we use tebusulin, but there are other regimes you can give. I like tebusulin because it's quick and easy and wears off very quickly. We shouldn't give them anaesthesia, though there is some arguments that if you're going to offer repeat ECV, which you can to some women, that doing some sort of analgesia, if they hadn't tolerated it very well the first time but want to have another go, is something that is not unreasonable to do. And as we say, we should. I remember, I'm old enough to remember the days when women used to turn up to antenatal clinic and we used to do an ECV because we found a breech on the day in the antenatal clinic. And those days are over. We definitely shouldn't be doing them in anything other than a setting where we do have the facilities to deal with all emergencies and to make sure that they're monitored by CTG before and after the procedure. And of course, don't forget that your rhesus negative women do need to have a Clyhour and be given anti-D following an ECV because it is considered a sensitising procedure, even if they've had their full prophylactic anti-D courses. So going on to counselling, how should we counsel? And this is straight from the newest guideline. So these are kind of new bits that are in the guideline. And they're not really new. They're what really I would say many of you, I hope, are already doing, because they're what a good obstetrician would always have been doing, which is the first thing is that we're going to explain the risks to the woman. And we're going to explain to them that we know there is a reduction in perinatal mortality in babies that are delivered by caesarean section versus babies that are delivered by a vaginal breech birth. But you can sector that out, and some of that is because of the fact you're delivering them early, so they don't have stillbirths post-term. Some of that is because of all the intrapartum risks, because if any of you want to say you've never seen an intrapartum stillbirth cephalic, I would tell you need to get on the labour ward a little bit more, because they do happen, sadly. And, of course, some of it is avoidance of risk that we completely attribute to vaginal breech delivery. And only the latter, of course, is specific to vaginal breech. And, of course, you can try to quantify those for women. So, and then we obviously need to go through and do the quantification. And the first one, obviously, is perinatal morbidity. And we have to tell them they've got lower APGAR scores, and they're more likely to go to the neonatal unit. I say I use a 1 in 23 risk for a vaginal breech, and that's where I do use the term breech study, because there's nobody else come up with a statistic. There's increase in serious short-term complications, but there's no increase in long-term morbidity for these babies, and we need to tell them that, and no hiding it. And then when we come to perinatal mortality, we've told them this first thing, but we have to give them the statistics, so that effectively there is a 0.5 in 1,000 risk of dying as a result of an elective section, a 2 in 1,000 for planned vaginal breech, and a 1 in 1,000 for a cephalic. So you give them the numbers and you help them go through that. And, of course, we need to make sure that they're aware, because it fits into this group, that we know that if you've had a caesarean section as a woman, that there is a significant increase, albeit it may not be causal, but there is an increase in stillbirth in future pregnancies. So we need to discuss all of that. And we need to discuss maternal risk as well. Remember, it's not just the baby. So for the woman, we tell her that her caesarean section risk, and this is the one I always say to them, that it is lowest with a successful vaginal breech. It's highest with an emergency caesarean section, because your vaginal breech failed, and then you've got the group in the middle, which are the planned caesarean section. And, of course, reminder that we have to tell them there's a 40% chance, if we're going to properly manage her, that she'll end up with a caesarean section. And we explain the risks of caesarean section. I'm not going to go through those, but we need to just remember to tell her about the increased risk of complications in future pregnancies. And I would say that it's one of the ones we're very bad at. You know, how many of you include morbidly adherent placenta in your counselling for a primary caesarean section? Good. Well, there's a lot of you, but I know I've listened to people in King's, and it's not routine. And we should all be saying to them, if you're going to have one more baby, it's probably not. But for those women who are planning big babies, then it's a significant risk. And my midwives say, well, no, we've just had the most horrendous case in King's. We were all pleased because she's lived, but she went to theatre last week with a 20% chance of dying she was given. This was 8 weeks after her primary section, where we'd left the placenta in because the whole left pelvic side wall was invaded by the placenta. And thankfully, our vascular surgeons, not us, managed to nibble away and get through every vessel. We'd embolised her, we'd done everything, but these are serious complications. She'd had 4 previous sections. And, of course, we need to individualise her risks of those things based on her history and her reproductive intentions. If you've got somebody who says, look, I'm 45 and I'm only going to have one baby, then fine, look, the section really is not an issue because she's never going to have. But we need to, and this is all part of Montgomery, that we include this sort of counselling. So, again, I'm not going to go through this, but this is an algorithm that you can use, and it's just this important thing that what for a term labour, that sometimes we do have to move into a world where we do recommend. And there's certainly here, so when we're recommending, so we can make a recommendation, but that doesn't mean to say we won't listen and do the other. So really what we're saying here, so this is an in-established labour, so we're going to recommend where everything's normal and there's an experienced doctor around, that she considers the option very strongly of going for a vaginal birth, because now we're in a world where the maternal risks of a caesarean section are that bit greater. But you can all go through this afterwards. So about making sure we put the woman there and that we discuss it, but that we interpret the risks. So what is the big problem? What is the elephant in the room about breech delivery? And this is the elephant in the room about breech delivery. This is based on King's. We have just over 5,000 deliveries now. We are pretty good, and we do recommend ECV to everybody. So that would give you, if you use a generous breech rate, about 250 women. And we do 36-week scans, so we do find them all and get an opportunity to do ECV on most of them. So if you do ECV and then you use the same exclusions here I've used as Promoda would have used with the standard rates, and you make sure you counsel and we base it on Promoda again, what we get down to effectively is we will have really a very small number of women, 90 women, who will actually contemplate vaginal breech delivery if we've counselled in a truly unbiased way in the same way as Promoda do. Of those, a significant number of them are going to end up with a caesarean section in labour, so nobody's going to get to do a vaginal breech. We're going to do a caesarean section for her. And then what we get to is we get down to the fact that we've actually got 60 vaginal breaches. Now, I would put it to you, if you're managing them properly, and I love those people who, if I put your hand up now, said, who's done 10 vaginal breaches in the last year? Don't put your hands up, okay? Because it's impossible, really, for you to be doing it unless you are over-intervening, because you're over-intervening, that's it. Because the evidence says that if you do nothing and you sit in the coffee room, half of them, the midwife will come back and tell you that the breech is delivered. Only half the time will they need you. But in fact, we sit in the room and we're so desperate to get signed off on our OSATs and make sure we've ticked the right boxes that we intervene unnecessarily. So what actually it comes down to is at King's, if all of them who potentially could went for a vaginal breech, and they don't anywhere near this, have got 30 vaginal breaches a year. I have 13 consultants, 30 trainees, and I've got 5 midwives sitting in the second row here who would all love to do a vaginal breech delivery. There just isn't enough to go round in terms of us all getting our training. And this is why we've also, a combination of the term breech study, which has told us all to do sections, plus the fact that we're not getting any experience, means we've become afraid, and so we're now in a cycle where it's a self-fulfilling prophecy that we start to do too many caesarean sections. So less than 1 per year. So what do we have to do? We have to do simulation, and of course I would recommend all of you do whatever it is, your local skills training, MOE. Also, I regularly practice my manoeuvres on a dummy. It's just very important so that in the situation where you have to do them, you're slick. So pearls of management. What type of breech is this? What type of breech is this? Okay, it's what everybody says. You tell me it's not a footling breech, okay? It's a breech with a prolapsed foot that was a flexed breech, and it's the most common reason that we end up doing emergency caesarean sections on breeches. So my first pearl of wisdom to all of you is if you're going to do vaginal breech delivery, stop looking for a reason to do a caesarean section and try to deliver the baby vaginally. Footling breeches are incredibly uncommon, less than 10%, but flex breeches occur in 3 in 10 breeches, so that is just a foot prolapsing down as a normal process that will happen in a baby that's coming down with flexed legs. And if you do a VE, you'll find the breech is completely filling the pelvis. So these are things, and we could go through all of these things, but just very briefly, you can give Syntocin on women with epidurals particularly and poor contractions. The RCOG guideline does go through this as a point. It's illogical not to give it. We need to make sure the women are in good positions. Putting them flat on their back is definitely not going to help them to labour. These women need to be upright and mobile, which gives us problems with monitoring, and we need to be prepared to make sure that we try and monitor them as upright as possible. and think about certainly intermittent auscultation until they're in established labour. So let's not put them on the monitor when they're only 3 centimetres. We need them in properly established labour. So analgesia, we know that it reduces mobility, but of course it is pain relief, and many women will want it. But of course we've gone into a world where we recommend it to all women just in case we have to do those manoeuvres. My approach to this is to explain to them that it will reduce their mobility, and that actually if they're aiming for a vaginal breech, we should be trying to support them in other ways and avoid epidural for certainly as long as possible. So low dose is what we should be doing. But the particular thing is, please don't top it up fully in the second stage of labour. So the worst one I've had ever was being called in to assist the senior registrar who's looking forward to doing a vaginal breech delivery to find he'd not only transferred her to theatre, I'll get onto that in a second, but he'd given her a spinal anaesthetic because she had no epidural. So I told him to do a section and went home. Because women have to be able to push. They have to be able to push because you cannot pull a baby out until it has actually reached a certain stage, maternal effort. So spinal is wrong. Good second stage management, so active second stage when the breech is visible. RCAG guideline goes through this. We should let the passive second stage for as long as possible until the breech is on the perineum, and then get the woman pushing at that space. And again, strict protocols, and certainly at King's we say that if she's pushed for 2 hours and the trace is still normal, we should have a section earlier than that if the trace was abnormal, but she should have a caesarean section. There's no heroics. They have to get that breech delivering themselves. Delivery in theatre, I absolutely hate it. We don't think about theatre. It's that marvellous place we go to where we get our surgical experience. And it's not, if you take a woman who's never been in theatre before into theatre, immediately catecholamines go through the roof. What happens? Her contractions stop. And we definitely, the last thing you really want to be doing on a vaginal breech is putting oxytocin on in the second stage. But that's where you would be if you transfer into theatre. So I would say do it in a room close to theatre with everybody on standby. I could put in as well that I think doing these sort of things in theatre reduces our resilience and makes us far more likely to intervene in some way. So I think we do unnecessary interventions where we go into theatre. So we're going to aim for a spontaneous breech delivery, and I think I've made that clear. The evidence says if you sit in the corner and drink coffee, 50% of them will just come out of their own accord. And, of course, that's without you doing anything whatsoever. And that is more common in multips and primips. It's going to be more common in small babies than big babies, though, of course, the term breech didn't show any big difference, but we all know multips deliver much more easily. Any stimulation of the baby risks actually making the situation worse. So it's important to remember that the minute you start to intervene with one intervention, it's more likely you'll have to do a second intervention, because if you actually stimulate a baby, and I'd have to say I did vaginal breeches in the days where we were allowed to sit there and tickle their feet and watch them kick. And of course, I got lots of experience of managing nuchal arms, because you tickle a baby's feet and it does this with its arms because you've startled it. So try not to stimulate the baby at all to avoid anything like that happening. And the most important thing I would say to you is the art of a breech delivery is understanding the normal mechanism of labour. And if in the other context is I do give a lecture, go through it step by step with your dummy. Understanding the normal mechanism of labour allows you to see when the normal mechanism of labour has stopped, and that would be a point where you need to intervene, because the breech is beautiful because of the way it comes through the pelvis. The bitrochanteric diameter has to rotate to come through. Then you get the biacromial diameter having to, and then finally the head. And there's lots of little manoeuvres that happen for the breech. Of course, in a multi, it all happens so fast you don't see it. But in a primate, next time you've got one, watch all those little manoeuvres. They really are very beautiful in terms of the way they happen as the baby negotiates the pelvis. So why do we need to intervene? And to find a point on it, the reason vaginal breeches do worse is because they've got an increased risk of hypoxia because of cord compression. The cord, because of its position when a breech is coming down, in the first stage you're more likely to get cord compression decelerations, which means that a baby is more likely to be developing a sort of subacute, long-term hypoxia as part of that. And the key to that is definitely keep the membranes intact as long as you can, because it will reduce the chances of that. But it also gets much more likely in the second stage. And this is the model, but it's just to remind you, and this will certainly, maybe you're all much cleverer than me, but it was an epiphany to me when I realised that this was the problem with vaginal breeches. As the body comes down and the head enters into the pelvis, there is so little space now for the cord, which has to go up past the head, that as soon as you've actually got the breech delivering to its umbilicus, you've now got pretty much complete cord occlusion for this baby. And that's why we've always known that was a critical point. The old thing where you pull the loop of cord down doesn't help in the slightest because the cord is still behind the head. We recognised there was a problem at that point, but we really didn't know how to address it. But there is no way to address it apart from a realisation that this is what happens. Short cords obviously can be problematic, and you need to bear that in mind. If a breech isn't descending, a short cord can be a problem. And placental separation can happen so that as the head descends into the pelvis, the uterus effectively being decompressed means that it can contract down with placental separation. So again, another situation where you've now got complete anoxia going on. So you need to have thought about this and have a management plan for how you're going to manage this. We need to warn the parents and obviously have a neonatal team there because the baby will have lower Apgars. We need to try and make sure it enters the second stage in good condition, and that's where continuous electronic fetal monitoring comes in. And we watch in the second stage for subtle deterioration on the CTG and intervene at that point if it happens. And of course, if we've got delay in the delivery of the baby following visualisation of the cord, we've got our 3-minute rule, and we now need to do interventions. So this is your chance to do those interventions that if you want to, or you want to learn to do them. So this is a sort of CTG that you get. Breeches do get very bad second stage CTGs. This was she was a multip who was delivering. You can see that it's a good trace because you can see they said here FSE applied. So they put an FSE. You can see pushing. Unfortunately, had no TOCO because she was very mobile. So they'd compromised on just the FSE rather than that. So she was very mobile. She was pushing. But look at the falling baseline. Fortunately, so they did spot this and they said the CTG, something strange is happening to it, so they called me in and I went into the room at this point, but I was pleased to see that I was just thinking I would need to do something because this is a trace that this baby has got a very falling heart rate, and this is often what you'll get in second stage breeches when she pushed the baby out without me doing anything. But if she'd been a primate, it would have been a point where we'd need to consider an intervention. What was that? Yeah, you put an FSE. It's not an FSE, it's an FBE, isn't it? Fetal buttock electrode, and that's it. But it works very well. Get it over the sacrum. So you just need to don't put it on the genitalia, shall we say, without putting too fine a point. So you just need to, but it works very, very well. And it's a perfectly reasonable take, including the LCAG guideline. Is something that you can do, but not fetal buttock sampling, I should say. We don't recommend FBS in that sense. So prolonged second stage, you need to have strict guidelines. I've said that already. If your CTG becomes pathological, you need to consider whether it's too late to do a caesarean section. And if the baby's only just starting to deliver and you get a very bad CTG, particularly in a primate, you still can deliver the baby very easily by caesarean section. Breech manoeuvre, I'll mention in a minute, is something that you might want to do at a very early stage. If the back's rotating downwards, we don't want an OP head, so that's the first time you're allowed to touch the baby, but you've now touched the baby, be prepared to do the rest because of the fact you might have stimulated the baby. And if the baby's delivered to the level of the umbilicus, this is where you need to think about an episiotomy, which is not routine. Do not do routine episiotomies. It's rarely a perineal problem in terms of what's happening to this baby. The arms are extended. We either scoop them down using a Breech manoeuvre or deliver them using love sets. And if the arms are nuchal, you can attempt love sets. And I have to tell you, if it's true bilateral nuchal arms love sets doesn't work, go and work with a model and you'll realise that that's true. If the arms haven't delivered and the head doesn't deliver, then you can either do Morris's Smellievite or forceps. And if the head is really high and outside the true pelvis, this is one I haven't got an answer for anybody, but you need to, again, think about your normal mechanism of labour. And if it's outside the true pelvis, actually what you need to do usually is rotate it to being OT, allow it to drop into the pelvis, and then it will rotate to effectively be in a direct position again. But you need to rotate it to be OT. The final thing I want just to mention is just to mention to you, is there anybody here who does Bract? No, silence. If I gave this lecture, there we are. Okay, you used to do it in Poland. Everywhere in Europe, bar the UK. It's a Brexit thing, isn't it? So everywhere in Europe does BRACT, but for some reason we never took it on in the UK. It was actually described in 1935 originally. It's a very old-fashioned technique, and what it was originally described is that effectively what you do, as the baby's delivering, you take hold of the presenting part and you basically use the technique describes using a force equivalent to the weight of the baby, i.e. not a lot of force, and you actually sweep the baby up in an arc towards the mother's symphysis pubis. And effectively, as she's pushing, with an assistant providing suprapubic pressure to apply pressure to the head to cause flexion. As I say, it was strongly endorsed by an American called Plentel in 1953, and in Europe, everybody went, wow, what a good idea, and started doing it, and in the UK, we ignored it. But it is a technique. Now, the reason I think it's, and I've never had the opportunity to do it, but I would try it if I was in a dire emergency and I felt I needed that situation where somebody was delivering. And the reason I would actually comes from midwifery evidence, and this isn't a very good example, but only catch over their nose, because this is me. I'm not really doing a BRACT here, because I should have hold of the baby flexed and be lifting it up, but effectively you take the baby and you sweep it in an arc. And if you think about what they do, when midwives do when they do their all 4 vaginal breech deliveries, what happens? How much weight is the baby using as it sweeps itself towards the maternal symphysis pubis? It's using a weight equivalent to the baby, because that's all it's got, isn't it? And that's what they do. And so these are 2 effectively synonymous techniques. The midwives, when they do all 4 vaginal breeches, are effectively allowing nature to do BRACT. So to me, it does make sense that it's something. And Premoda, every baby in Premoda was delivered using a BRACT technique. So that's about all I've got time for. I always finish by saying this thing, which this came from Plentel, who I just said endorsed BRACT, and he said the art of waiting is a difficult one, and not many obstetricians have either the courage or the patience to sit idly by while the breech delivers spontaneously. This has become even more difficult if the inpatient obstetrician has a century of tradition as well as the words and writings of all contemporary teachers behind him. And this was at that time a rail against love sets on every single baby, which pretty much we did used to do in the UK up until about 15 years ago. And I would just say to you, be aware that it shouldn't be automatic that every breech is delivered by caesarean section, and we shouldn't let that become a medical tradition that we recommend caesarean section. It would be wrong for us to do that. All delivery options should be discussed where there's no contraindication in a very, very clear and unbiased way to allow the woman to make her decision. And just to put you, the biggest contraindication to vaginal breech delivery is the bottom one, which is likely to be our lack of vaginal breech delivery. So this is a plea to you all. Go back, get the models out, practice, start thinking about vaginal breech, but also have an awareness that you don't need to intervene in every breech. Thank you very much.